All right, so a couple minutes late because of the usual technical problems getting started here. So this is going to be part 2 of diagnosis and management of PIDD, or that gets renamed. What's the new name?
Inborn errors of immunity.
Inborn errors of immunity. So, Barb, I know you're out there listening. Send me a text to make sure the sound check is good, that the video is good, and I'll interrupt the speaker if we need to for better audio. Other than that, let's go ahead and get started.
Okay, good morning. Thank you all for coming. Today, this was the objectives last week, where we were going to talk about some clinical patterns of primary immunodeficiencies and discuss some of the screening laboratories, and then briefly discuss some of the treatment modalities. And I promised today to sort of present mainly of the clinical cases. So just to summarize, what we talked about is primary immunodeficiencies are a group of inherited disorders of immunity, and they have been classified now as inborn errors of immunity. The classifications include the largest group of antibody deficiency syndromes, which are this dark blue here, the defined syndromes, which include the DeGeorge or the Wiskots, combined immunodeficiency, and both autoinflammatory and defects of the immune dysregulation with defects of phagocytes here. We also talked about the fact that there's over 300 diseases and that there's over 300 plus genes, and that therefore trying to understand the clinical patterns that guide the workups and to make things very simplistic, we decided to follow the classic teaching algorithm of understanding both defects of adaptive immunity and defects of innate immunity, recognizing that the majority of the defects of autoimmunity are going to be identified by measuring serum immunoglobulins and vaccine responses, that defects of T-cell immunity are characterized mainly by the need and the pathogens related to that are usually intracellular and require activation of T cells, and that the recognition of these T cell defects are going to be by looking at lymphocyte subpopulation and proliferative responses, and that defects of innate immunity include phagocytes and complement, and that today the well-known and recognized defects of phagocyte killing include your chronic granulomatous disease, where looking for actual killing in neutrophil oxidative burst assays are going to give you those analysis. And the simple CBCs recognizing the phagocyte defects of neutropenia. And surely,
a question about complement. I've always wondered why they use sheep red blood cells to test complement intactness. Why is that?
I don't know.
Sheep don't complain.
Sheep don't complain.
So today I'm going to discuss a group of clinical scenarios, and basically I've divided the clinical scenarios in defects of antibodies, defects of cellular immunity, phagocytes, and then I'm going to show you some more rare conditions, and just make a few points on each of these different diagnoses. So all of these diagnoses are patients that I've followed over the years. So this is the case of a boy with recurrent sinus-pulmonary infections and an epidural abscess. So he's a 10-year-old boy who first comes to see us and has a history of recurrent ear infection starting at 4 months of age, has resulted in several tubes, has a history of chronic sinusitis that usually started around 2 years of age. By 8 years, he has mastoid disease and has been admitted with an epidural abscess. He's had multiple pneumonias, one of which resulted in an ICU admission. He's diagnosed with asthma and is on short-acting beta agonists and inhaled corticosteroids. He's had some intermittent diarrhea, but not consistently, and mom has always been concerned about the poor growth because comparing her and her husband, the child seems to be much smaller than you would expect. And there's a family history of a boy who died at 14 days of life. There was a question about the etiology. There were some questions of because they may be related to prematurity. So the laboratory studies based on what we discussed, just basic simple screening of a CBC, showed that the patient had no evidence of neutropenia and normal absolute lymphocyte count. A screening just of serum immunoglobulin demonstrated that the patient was pan-hypogammaglobulinemic or agammaglobulinemic, noted by the levels of immunoglobulin. And these lymphocyte subpopulations that we also recommended includes both T, NK, and B cells, and what you can see here is that this child has a CD19 count of less than 1%. So, want to guess the diagnosis? XLA, right. And so Bruton's X-linked agammaglobulinemia was the first of the immunodeficiency, one of the first of immunodeficiency that really honed on the fact that antibodies were critical for host defense. And this is the classic paper by Colonel Ogden Bruton. And what you can see in this slide is, and this is too small, but it's in your handout, it's really interesting to read the actual abstract. But what you can see is that there's an absence of the gamma globulin fraction here. And the reason this kid's serum got there is just a serendipity because they had a new Thesalius machine that was bought by the Walter Reed Hospital, and so they were testing the machine, and this kid had been admitted multiple times with strep pneumosepsis, and they said, oh, let's just put that serum on, and that's how this patient's, this was recognized. So, things to know about X-linked agammaglobulinemia. First of all, it's an X-linked disorder. Usually the classic clinical presentation is greater than 6 months of age, as maternal antibodies will wane. The defect is in a B cell tyrosine kinase, so Bruton's tyrosine kinase, which is critical for B cell development. As all antibody deficiency syndrome, these patients have infections with extracellular pyogenic organisms such as strep pneumo or staph or Haemophilus influenza. All of the immunoglobulins are usually below the 95 confidence intervals, and many of these patients will have absent B cells, but some of them may have some B cells, and some of these patients may be diagnosed a little later. One of the classic findings on physical exam is the lack of tonsillar tissue, especially the toddlers. But what I wanted to show this group is that this is a review of 200 plus patients that Jared Wittgenstein had put together from data of the USID-NET looking at age and diagnosis of patients with X-linked agammaglobulinemia. And what you can see is that if you have a family history, it's more likely that you're going to make the diagnosis earlier, between 6 months and a year. But if you don't have a family history, these patients can be diagnosed at any time, and including in late adolescent and young adulthood. And the reason is because these patients develop recurrent infections with bacterial pathogens that are treated with antibiotics properly, and so they get recurrent antibiotic therapies and respond to antibiotic therapy properly as well. So one of the key questions now is, as we've made the diagnosis of all these children, they're in their 40s and 50s now, is what are the long-term outcomes for XLA, and what is it that you need to recognize? And these patients will need the immunoglobulin for life. And one of the biggest problems is that chronic rhinosinusitis continues to be, and pneumonias continue to be a problem for these patients. Importantly, enteroviral infections can be life-threatening. And unfortunately, why that is for many years was not understood. But we do know now that BTK is critical for STAT1 expression through activation of TLR9. And so there is a thought that that may be the contributor in why these patients with X-linked immunoglobulinemia develop these enteroviral infections. It is very difficult to treat. There's no standard approaches, and there are no good therapies. And this can result in a progressive neurodegenerative disease that is eventually fatal. The other thing that's important to recognize is about a third of these patients will develop some GI manifestations that include, it's almost like an inflammatory bowel disease. And they are difficult to manage too. And about 10% can be diagnosed with IVIG and require immunomodulatory therapies, but these are difficult to manage and hard. So there is a lack of proper and good therapies. All of these pathogens I identified in the slide, Giardia, adenovirus, and C. diff are common in these patients. So these should be monitored if you have a patient that presents with diarrhea. And in fact, some patients end up requiring TPN therapy. So it's important to recognize these which contribute to not only morbidity, but quality of life. Finally, there is an increased incidence as compared to the general population of certain malignancies. So being aware of this, but not, and these malignancies not only are lymphoreticulated malignancies, but malignancies like colon cancer, adenocarcinomas, and osteosarcomas have been diagnosed. So long-term care patients who have XLA, you're going to be following these patients over time, and then these are the problems that you're going to need to, you will encounter. And so in terms of monitoring, there are many questions that are not known, and there's no standardization in terms of care. And so I put some of these questions up on the board to be a little bit provocative, and that is, if you have a patient who, classically like the patient that we had at a young age, who actually was late diagnosis at almost 10 years, do you need to do a genetic diagnosis for all your XLA patients? And I don't know how many of you, how you all feel about it, but my personal opinion is that you should have a molecular diagnosis for several reasons. One is that if you have the molecular diagnosis, as they move into adulthood, it's less likely that you're going to the diagnosis is going to be questions, and the insurance is going to not approve your immunoglobulin therapies. So that is one of, from my perspective in terms of day-to-day care, I think that's one of the critical questions for patients. What about, we know that these patients have significant problems, chronic rhinosinusitis and pulmonary disease. Do we need to be doing chest x-rays as a baseline on these patients? And do we follow PFTs on these patients? Some of these patients, when they get into their third, fourth, and fifth decade of life, may have some bronchiectatic changes. And so how do you monitor all of that? Should you be doing high-resolution CT scans? And how frequently should you be doing, especially if you have evidence of bronchiectasis? What are the role of prophylactic antibiotics? And we talked about that briefly last time. Do these patients benefit from prophylactic antibiotics? There's no data on prospective studies, but these are questions that are important, and many of us who follow these patients will use prophylactic antibiotics with little information. And one of the key questions is these enteroviral infections, which really create, contribute to morbidity and mortality. And we really don't have a good therapeutic approach for this. And I think quality of life measures is important. Thinking of the future and what therapeutic options they would have. There are countries around the world that offer transplantation, bone marrow transplantation for these patients, and there are opportunities for gene therapy trials for BTK to be developed. And the question is this something we should be doing or not? So I think there are a lot of questions as we move into a new era of adult patient with XLA that we still need to answer.
What you said maybe last time.
Case report.
Frequency of this.
On your case report, they had a sibling that died at 2 weeks of age. Is that too early to be related to XLA?
If it was an enteroviral infection, it could have possibly been related to the diagnosis, absolutely. Even E. coli sepsis has been associated with antibody deficiency.
Wouldn't you have the maternal antibody at that age?
Yes, you should have had maternal antibodies, but like E. coli sepsis is one of those that is not necessarily maybe well protected.
What did you say last week is the frequency of this disease?
1 in 100,000, we think. Okay. I just wanted to be a little provocative, and I wanted you to think about these as you follow these patients into adulthood.
Are you going to give us your answers to this quiz, or are we just supposed to answer just number one, but you left the other four?
I have a question. How about with regard to the gastrointestinal thing? How about prophylactic use of a microbiome altering probiotic, mega probiotic therapy? Does that help in these with the GIs?
Yes, Scott Snapper at Harvard is really looking carefully at the microbiome of patients with XLA, CVID, and comparing to normal to the general population. I think there's a lot of work that needs to be done, and that's an important question, and those are areas that are areas of investigation.
There's an interesting editorial by Mandel from the infectious disease textbook about what antibiotics do to the microbiome and how it's maybe not as good a thing as we thought we were doing. It was a 2-page editorial that he sort of beats himself up for all of his infectious disease work.
It's all about balance, and if any of you are going to CIS, I said it last time, there is a prospective trial that will be presented from Europe on the use of prophylactic antibiotics and its benefit or not in patients with antibody deficiency. So stay tuned. Okay, let's talk about this one. This is a case of a girl with recurrent ear problems. This is an 8-year-old female, has a history of asthma and allergy. She has a history of recurrent ear infections and very frequent purulent rhinorrhea. She receives antibiotics anywhere between 6 to 8 times a year. She always gets better. She's got occasional diarrhea. It's been identified as having giardia. Her family history is negative, and on physical exam, she has a myringotomy tube in place, and there's drainage from the left ear. She does have some cervical adenopathy. And this is, again, the standard, simple laboratory testing includes a normal CBC, a set of immunoglobulins that's pertinent for absent IgA, and she has absolutely normal vaccine responses. So, things that you should know about IgA deficiency, which I'm sure many of you follow, it's fairly common. If you look at blood bank donors and you look at the prevalence of IgA deficiency, depending on a population, this can be as frequent as 1 in 400 and 1 in 700 individuals. The definition of IgA deficiency requires that patients are greater than 4 years of age and undetectable IgA. It's not an IgA below the normal value. It's undetectable. That is the definition for IgA deficiency. These patients, most of them, those if you just look at the general population and look at the patients that the individuals that are identified through blood banks, most individuals with IgA deficiency are asymptomatic, but the ones that you will see will have recurrent infections, mainly sinopulmonary infections. Some of them will develop some autoimmunity over time, and some of them may be atopic. So I think it's important that even though IgA remains an antibody deficiency that perhaps may not be as severe as some of the A-gamma globulin patients, that these patients should be followed and should be followed by an immunologist at least on a yearly basis. Gastrointestinal manifestation is also not uncommon, and so looking for pathogens that may have therapies like Giardia should be pursued. Use of antibiotics promptly. There is a question again of the use of prophylactic antibiotics, and again I'm being provocative. Some people will use them. There is no prospective data. Management of asthma and rhinitis, development of autoimmunity, and importantly, IgG therapy is not indicated in isolated IgA deficiency. So there's no indication really for IgG therapy. Now, the reason you need to follow them is especially in pediatrics, not so much in the adult world, but in pediatrics, some kids that start off with IgA deficiency may develop a CVID-like picture down the road. So it's important. I like to at least follow them once a year or at least every 6 months if they're having issues, certainly more frequently. But I follow them over time.
What's the difference between the vast majority who are well and the few who get sick?
That's the $60,000 question, and nobody really understands that very well.
More than 64,000.
Do you push vaccinations in these kids pretty hard?
Yeah, so I think everybody needs to be vaccinated, but these are not like they should have very normal vaccine responses because it's part of the evaluation. So I would make them follow the standard vaccination recommendations.
On the molecular side of it, what's the time with atopy? Have there been some transcription factors that are shared?
Yes, I think there are some papers that suggest that there is that relationship with atopy and others that don't. So I don't know if there are any particular molecular signatures that have been identified, maybe with HLA variability, but I don't know that's been confirmed. Does anybody?
I mean, atopy is pretty common. Maybe it's just coincidence.
It could be, but I mean, perhaps there are some reports that it's difficult to interpret some of these papers because there are reference and referral papers that maybe there may be a referral bias there, and so you may see, individuals that are coming to AI programs where you then identify them as having ADP specifically.
What do you tell patients about receiving blood products?
Yes, so
talk to Hans about this.
That's a good question. There is, and this is the question really relates to the complications related to gamma globulin infusions in patients that are IgA deficient, and whether IgA content in IgG products contributes to anaphylaxis and anaphylactoid-like reactions. And there have been reports of that. However, there are no good data and laboratory methodologies that allow you to confirm that, right? And so, personally, I don't make any recommendations, and I don't necessarily check for IgA. And certainly, anaphylactoid reactions occur with gamma globulin products, and anaphylaxis can occur, but I don't necessarily know if this is related directly to IgE, anti-IgA. These are early studies that were in the 90s, came out of mainly and these are all homemade ELISA kits that were created. I've not been able to reproduce those, and there's not data outside that will allow you to confirm that, right? But we've all seen anaphylaxis-like or anaphylactoid-like reactions in patients with gain of function. But I don't necessarily check for IgA. And in particular, patients like for Kawasaki disorders that require immunoglobulin infusions and hospitalized, there is a lot of the package inserts will tell you to check for IgA. I don't think that there's a lot of data to.
What's the incidence of people who don't make IgA that actually make IgE? How high a percentage of patients is that?
I don't know, but it's not uncommon to see that imbalance. In other words, Bachman used to say, if you can't make A, you make E. But what is that number? I don't know the answer to that. It's more of that observation that we've all seen, right?
I have observed in at least 2-3 patients that IgG as high as this patient, 1,600 or something. When I sent, or somebody has sent subclasses, and they are found to have IgG2 deficiency, but IgG1 MGUS.
So in the early 90s, there were a lot of papers that looked at the association of IgA deficiency with IgG2 subclass deficiency, mainly coming out of Sweden. And that's an observation that is there. Is there a value in necessarily checking subclasses? Personally, I don't find that value because it's not going to change how I manage a patient. If the patient does not respond to vaccines, I'm going to manage them the same way, whether they have a low IgG subclass or not. There are individuals that have absent IgA, different IgG subclasses without any clinical abnormalities, especially IgG4 deficient. There are a lot of individuals that are IgG4 deficient that necessarily do not have any clinical relevance. So it's very difficult, and I feel that IgG subclasses, even though in the 1990s, early 90s, really created an interesting observation, and certainly each subclass has a clinical relevance, and in the laboratory they do have relevance. I don't know if in clinical practice and day-to-day practice it provides any additional information other than if you see the IgG4 lymphoproliferative type disease, which is different. Okay. Let's talk about the next case. This is an 18-month-old with recurrent otitis media who's in daycare. He comes to you, has had already 8 episodes of recurrent otitis media, 2 episodes of sinus disease. He's been seen by ENT, and they're going to do some sinus surgery in an 18-month-old. He responds very appropriately to antibiotics. He is in daycare. He has on physical exam a nice tonsillar tissue, and he's got a healthy 4-year-old brother. And these are your laboratory studies. What you can see is the IgG is 120, which is lower than the normal end of normal here, with a normal A and a normal M. He has a normal CBC. His responses to vaccines are completely normal, and his B cell counts are normal. So for the adult internal medicine in the group, just wanted to, every 10 or 12 years, there's a new paper that looks at the frequency of how many is it normal and whether you're in daycare or not in daycare. So this is from a long time ago, but what you can see is that the frequency of upper respiratory tract infections in children less than a year is anywhere between 6 and 7. And if you look at it, it's usually between September and April. And so what happens is that means 6 or 7, they're having problems almost on a monthly basis, and that still would be within the normal range. And with an ear infection, maybe 1 or 2 at that time. So it's good to know how frequent these episodes are. After the age of 2, it's not common to have recurrent ear infection. So that is a little bit of a clinical parole and a red flag that you need to be thinking about. If you see a kid after the age of 5, they shouldn't be having ear infections are recurrent, and they shouldn't be having need for tubes. I'm talking about the normal, healthy appearing child who's been growing appropriately, not a child with any of the syndromes, which could potentially explain that. But I just wanted to put this slide up here so that gives you a sense of what's the normalcy of recurrent upper respiratory illnesses in these toddlers who are in a daycare environment. So this patient has what we call transient hypogammaglobulinemia. This is a diagnosis of exclusion. These kiddos have low IgG. It is thought to be a prolongation of that physiologic nadir as maternal antibodies start waning down at around 3 months and sort of disappear by about a year or so, more or less. These kids have normal responses to vaccines, so vaccination and looking at vaccine titers are very helpful, and they have normal B cells. Why that is, why that immunologic immaturity, if you will, is not really well understood. That all said, in general, these kids do fine, and over time, as long as they're properly vaccinated and you have good titers, most of these kiddos will normalize by around anywhere between 3 and 5 years. But there's some that will linger on, and I think it's important to follow them because some of them will develop maybe into like a CVID-like feature. So it's really hard in the children as your immune system is maturing to sort of predict which way you're going to go. Treatment sometimes can be difficult because some of these kids will have recurrent infections, and so there's there are lots of different recommendations. And in general, gamma-globulin therapy is not indicated. However, if you get a kid who comes in with strep pneumosepsis and pyema, and the only thing you find is a low IgG with normal vaccine responses, and you think that that's probably the case, but he's already had a strep pneumosepsis and pneumonia, you could argue that this is a kid that you could put on gamma globulin for a few years, but recognizing that you're going to try to take them off and discuss that with the family in that way. So it's not unreasonable to do it, but in general, most of these kids, you can reassure the families that they get better over time. So I follow these kids. I like the first time to repeat things at least every 6 months or so. And then trying to keep a close eye on it and make sure that they are developing and growing well. There's no evidence of failure to thrive or things like that that might clue you into a more broader defect.
That table you had showing the frequency of upper respiratory infection, if you extend that into adulthood, what should we as internists think is a normal frequency of just
Upper respiratory
in a healthy person?
Yeah. 1 or 2, a couple per year is not unreasonable. And usually it's during September. Hey, this is an adult case. These are your patients. This is a 42-year-old who presented with pulmonary nodules and splenomegaly. So she was perfectly healthy until the age of 30. She was diagnosed with the ITP. She had 4 episodes at times, and she treated with steroids and did fine. And then after that, she started having a lot of problems with bronchitis, and so she gets diagnosed with asthma. She gets placed on inhalers. And then one time, she gets admitted for 1 episode of pneumonia. But there's no pathogens. She responds well to therapies. And about 6 or 7 months after that episode of pneumonia, she starts developing lymphadenopathy and splenomegaly. So she's sent to the oncologist. She gets a lymph node biopsy and a bone marrow biopsy, concern for lymphoma. She has what is described as follicular hypoplasia with non-caseating granulomas in her lymph nodes, and the bone marrow is completely has no evidence to suggest lymphoma. So given her pulmonary nodules, she gets diagnosed with sarcoids. So she gets started on steroids. As a consequence, she gains 40 pounds, she gets extremely depressed. She gets another episode of pneumonia, she gets pink line for this, needing IV antibiotics. She develops a lot of fatigue and fevers now, and she really feels miserable, and she really wants to get off these steroids, and so she eventually gets off of these steroids, which did decrease the pulmonary nodules, but now these have returned, and the splenomegaly is massive. So she comes to us about 6 or 7 months after these. She's seen a lot of different docs, and these are her laboratory studies. And what you can see here is that her IgG is low, her IgA is undetectable, her M is low, so you can say that she has pan-hypogammaglobulinemia. She has low diphtheria titers, she has low tetanus titers, and she really doesn't have any protective titers to coccal antigens. And her B cell numbers, the percentages are barely there, but the absolute numbers are low. And these are her CT findings. What you can see is she's got some pulmonary nodules and almost like a reticular pattern here and here. And this is the spleen, which was impressively massive. And she also has hepatomegaly. So the diagnosis is? So she has common variable immunodeficiency. Okay. So what is common variable immunodeficiency? It really represents a real heterogeneous group of primary antibody failure symptoms, I think. And there is a consensus definition that Tony Bonilla put together, and it's worth reading, which is an international consensus group that really tries to define common variable immunodeficiency as having at least one of the characteristic clinical manifestations, which include infection, autoimmunity, or lymphoproliferation, and the presence of hypogammaglobulinemia with a low G and a low A or an M. That there was a lot of controversy because some experts felt that a low M wasn't clinically relevant, and really what you really needed to demonstrate it, there was a low A, because that means that there's poor class switching. Because M, if you remember, is the first antibody, so you're not class switching to M, you're class switching to A. So there was a lot of debate back and forth about whether we should include the M or not, but the general consensus is that to include either a low A or M being low. And you need to demonstrate at least some impairment in antibody production, either to T-dependent or T-independent antigens, meaning protein conjugated or polysaccharide vaccines. And importantly, and this is the critical and the most difficult, is you need to exclude other causes of hypogammaglobulinemia. And in general, this consensus statement suggests that there's really no indication for genetic testing for all CVID patients. And so I have the references here. So what I want to make sure is that we really dig into the different causes of hypogammaglobulinemia. In other words, CVID does not mean hypogammaglobulinemia. So if you have a patient with hypogammaglobulinemia that you want and needs gammaglobulin infusion, use the diagnosis of hypogammaglobulinemia and not the CVID diagnosis, because it creates confusion on part of the patient's side. There are many medications that cause hypogam, but importantly, glucocorticosteroids. So if you're on somebody on steroids for at least a couple of weeks, you will see that drop of IgG, and you can see lymphopenia. The question is the persistence. So unfortunately, we all get these patients when they're already on all these therapies, and how do you make the diagnosis? It's difficult. It's not straightforward. But be aware of these different changes. Of course, in the adult world, CLL, thymomas, and of course certain malignancies, and blood dyscrasias that you need to recognize. The other important thing is if you're hypogam, make sure that they're not losing it. So they can only lose it in 2 places, urine and stool. So all patients with hypogam, when you're doing that evaluation, should get an a urine analysis to make sure you don't have any evidence of ongoing protein losses. And number 2, make sure that there's no evidence of GI losses, or either whether it's a history of diarrhea, or you could potentially check for alpha-1 antitrypsin in the urine, in the stool to check that. So I've left all the other here so that you understand. Now, in terms of clinical manifestations of CVID, we know that these patients will have a myriad and a very heterogeneous presentations. But importantly, about a third of these patients will have autoimmune and inflammatory manifestations. And if you look at our patient, she had not only infectious, but she had a lot of these here, including the early presentation of ITP. And why is that important? Is because CVID patients will segregate based on whether they have complications such as autoimmune manifestation versus those that have mainly infections that once you start hemoglobin infusion, they do just fine. I just want to point out that chronic lung disease is an important contributor to morbidity, and that many of these patients have bronchiectasis, and you can see these classic changes on high-resolution CT. Unfortunately, there's poor correlation of PFT and CT data, and many of you know that. So the question is, how do you monitor these? And then finally, if you look at how novel technologies have changed the spectrum of CVID, you can see how there have been many different genes that have been looked at. And if you look at 2017, look at the number of genetic defects associated with CVID. So I think that there is a role for molecular testing in some patients with CVID, and especially if it's a patient that doesn't follow the classic infectious good outcome on gamma globulin therapy that does well. But those that have GI disease, or those that have the granulomatous lymphocytic interstitial lung disease, are important to monitor. And like with XLA, there are many questions that are related to CVID monitoring that haven't been clarified, and there's not a standard approach to these patients. So again, who needs molecular diagnosis? What is the best approach for the management of the granulomatous lymphocytic interstitial lung disease? Jack Brutus has a great protocol in place, but if you talk to others, you'll see that not everybody uses the same regimen of Rituxan and azathioprine on a regular basis. Some people treat with Rituxan and wait and see if those pulmonary nodules go on. So there's a lot of variability, and we don't have answers. Again, how should you monitor with high resolution? And we have, and I don't have time, but we have evidence that there is some clinical correlation between patients' clinical outcomes depending on how that B-cell immunophenotyping and the percent of decreased class switch memory B cells that these patients have. So notice that in the definition, B-cell immunophenotyping is not part of that definition, but we all monitor that, and how frequently should we be monitoring it is unclear. And then how do you monitor for malignancies? And what is it that you need to do? How frequently do you need to see that? And finally, we do know that in the adult autoimmune cytopenia, should you be recommending that all adult patients who develop autoimmune cytopenia get a set of immunoglobulins? And there's a study that Chris Wysocki is doing at Southwestern that is looking at that particular question. And the answer is, if you look at the guidelines specifically for hematologists, then it's recommended that these patients all get a set of serum immunoglobulins. So keep that in mind as you see these IPP and adult patients. So just to summarize, I'm not going to go into that, but this is a little summary of all the antibody deficiency syndrome patients. We have, this is the next case that I don't think I have a lot of time to go over, but this is a child with infant deprived, and this is one of my little kiddos, and this is a patient with SCID. And just to reiterate what we talked about last time, severe combined immunodeficiency is defined by a block in the differentiation of T cells with or without, with direct or indirect B cell impairment, and they may or may not have abnormal NK function. They're both inherent X-linked and autosomal recessive. The disease is fatal without treatment, and there are many defects. And I like to show this slide because it's an old slide, and what you can see here, you're never going to see this slide again. And these are patients here that have not been transplanted. So this is the purpose of showing you the slide. There are no slides where you don't see SCID patients not transplanted. They will die. But if you recognize them early and then you transplant them before the 3.5 months of age, their outcome is excellent. And this is the single Duke experience of Becky Buckley. So this is what led to pushing to try to identify these kids at birth before the infectious manifestations present. And this is how the TRECS were designed, were recognized, and was Daniel Dewitt, when he was working in HIV, that recognized that as T cells develop in the thymus, remember your T cells have an alpha and a beta chain. As the alpha chain is rearranged, there is a looping out of the delta locus, and these are little excision circles that can be PCR'd out specifically. And so these rearranged T cell receptor alpha result in these T cell receptor gamma excision circles. And it's a marker of T cells that are naive, that are coming out of the thymus. And so knowing that, Jennifer Puck did this study where she separated adult blood, and she took adult blood, and then she depleted the adult blood, and took a group of SCID babies, and what you can see is that there was undetectable TREC levels. And so this is what led to the development of the TREC assay for newborn screening, where you can actually do this test in 3 microliters of blood. This is a SCID implementation, and what you can see is in Washington, it started in 2014. And I just wanted to show you that and I can come at another time to give you the experience here in Washington with newborn screening. So the baby that I showed you before is what was in the past, but this is in the future. And these patients are still going to be here. This is an 11-year-old girl who was referred for management of CVID. She had a history of infections early on. She had septic arthritis. She had an EBV, sort of lymphoproliferative disease. She was being managed with gamma globulin infusions, and she got 4 doses of rituximab. And so these are some of the laboratory testing that she had when she came, and she pretty much met most of the criteria for CVID, so it was appropriately managed, appropriately diagnosed. But with time, the clinical phenotype, and that's why it's important to monitor these patients, was changing. And when she developed this lymphoproliferative disease and pulmonary nodules here, all EBV positive, and got treated with Rituxan, then what happened was that she never recovered any of her counts after Rituxan therapy. Not only did she not recover B cell counts, but all her T cells were dropping. So She was diagnosed at the age of 12 with a RAG mutation, a recombinant activating gene 1, which is a cause of classic SCID. And so this kid had been maintained alive because of the frequent gamma globulin, because of frequent monitoring, etc. But this is an example of when molecular diagnosis really provides you answers that can lead to completely different therapies. So I think there's a role for molecular diagnosis, and especially in the young children with CVID. Keep that in the back of your mind. Phagocytic defects, I'm going to show you, these are two patients. This is a boy who presents at 4 years with bisapatia, then nocardia, then aspergillus, and then lymphadenitis. And this is a girl who presents with an MRSA labial abscess, then gets admitted with pneumonia, and then develops lymphadenitis, which I'll show you here, and this is serratia. So this is a classic, both patients have classic chronic granulomatous disease in terms of pathogen. And what I just wanted to point out that if you see patients with soft tissue abscesses and lymphadenopathy, chronic gingivitis and periodontal disease, common, mucosal ulcerations, but here's the catch. It's the organisms. The organisms are going to give you the hint. And so recognizing them, and this is what I like to talk about, space, meaning the mnemonics for staph, pseudomonas, aspergillus, candida, and enterobacteriaceae. So keep those mnemonics. The pathogen is going to give you the diagnosis. And the testing in these patients is here. In the old days, we used to do the nitrogen tetrazolium, and what you can see is that this yellow stain once in patients that had normal neutrophil function will deposit and turn into blue. And since this is the normal, normal neutrophil nitrogen tetrazolium, this is a carrier and this is a patient. And we know now that, just imagine having to do this test and relying on somebody looking at these slides on a regular basis. This is now done through flow cytometry, and dihydrorodamine, the oxidation creates rhodamine, which is a fluorescent dye that can be measured, and so you can see this patient has no shift here in his histogram, and you can actually quantitate, and you can actually look at both identified carrier patients. So I'm going to skip this patient. Oh, no, I don't want to skip this one. This is my favorite disease. This is a teenage boy who's on gamma globulin. He's now 16. He was started on gamma globulin at the age of 2 because he had a lot of ear infections and sinus disease. And at that time, his IgG was in the 200 range. He didn't have any A, and the IgM was sort of borderline, but nothing dramatic. And had a lot of chronic sinusitis and some asthma, but he had some intermittent neutropenia. And then what happened is that the brother, at 3 months, gets admitted with PJP pneumonia. So, which test will confirm the diagnosis of your patient? What do you think, given that the brother has PJP pneumonia? In the interest of time, I'll tell you that the answer is 1. This is a kid with X-linked hyper-IgM syndrome. So things that you need to know about X-linked hyper-IgM. The majority of them, the large group of them are X-linked disorders, but there's some autosomal recessive. It's a defect in class switch recombination, and so they can't switch. B cells can't switch from M to A to G. The defect is in the CD40 ligand. These kids present with bacterial infections, but importantly, opportunistic infections. So you need CD40 ligand on B cells, on T cells to activate macrophages to clear the pneumocystis. These patients also get cryptosporidium. They get some intermittent neutropenia, and importantly, they get neuroendocrine tumors. And if you look at malignancies in CVID patients, these are the most common only in X-linked hyper-IgM patients. So those are a group of patients that I'm particularly interested in. And if any of you see these patients, please come talk to me because we want to study this. Keep in mind and keep X-linked hyper-IgM in your patients with CVID diagnosis, in your male patients with CVID diagnosis. These, because your M may be normal initially, and your G may not completely be absent, and over time you can see it. This is the critical, even though transplantation is critical, is curative. If you look up long-term retrospective analysis, there's no difference in overall survival with transplant versus no transplant. And there's a paper that just came out in JACI this month on the outcomes of transplantation for X-linked hyper-IgM, and what you can see is that even though the overall survival is 78%, engraftment is difficult. Many have more than one transplant, and what is the absolute number of, or the amount of T cells that we require that can express CD40 ligand that make it effective and cure the patient is not well understood, and that's an area that Troy is really interested in looking at carriers. So I don't have a lot of time.
You don't have any.
I don't have many. This is any time. So I'll stop here. I'll leave you the different cases there, and I think I'm done. Thank you for hearing me.
Not only two pages, personally, that's the best talk I've ever heard as an internist. I'll remember some of that for about 15 minutes. We'll have to have you back for more. There are other diseases you still didn't get to. And thank you very much. Honestly, I'd like you to attend these sessions so that there is more interaction between children's immunologists and our broader, mostly internist, conventional allergy group. Because I know before you came here, you not only did immunodeficiency, you did bread and butter allergy as well. So we'd like you to keep doing that. And quite sincerely, that's the best talk on immunodeficiency disease I've ever had. And I understand we have a good broadcast too as far as audio and video, so thank you once again. Who was the lead author on that last paper?
Oh,
You.
that's me. So that I'm interested in hyper-IgM. So if you have any patients, please come talk to me.
All right, any last questions? Otherwise, we'll wrap this session up. Jonathan?
I have a quick question about secondary immunodeficiency in the setting of diabetes. In this particular patient I'm thinking of, you'd have prolonged hyperglycemia due to noncompliance with medications. Do you have any idea how long it would take to correct, say, neutrophil function in particular, once the hyperglycemia is corrected?
I don't know that, and that's an interesting observation. So in diabetes, I think mainly of T cell defects, for example, and we see that in some of, and we didn't have time, but some of your adult patients with the DGeorge patient, you need to be thinking about some of these autoimmune defects. I'm not aware of the impact that the glycemia, the degree of hypo or hyperglycemia would have on IgG or antibody production, or for that matter, neutrophil function. We do know there's a lot of data on abnormalities of neutrophil function in patients with renal insufficiency and azothemia. That's very well described and understood. But I'm not familiar with antibody or function in diabetes, to be honest with you, other than the mechanistic thought that antibodies may play in the destruction of them.
So that was something I picked up in some reading, and the clinical scenario is he's a diabetic 60-year-old who had a joint replacement. He's had septic arthritis 3 times in the last year, and I was consulted only on the question of drug allergy, but I was trying to step back and look at the bigger picture. And besides the obvious issue of hardware, Thinking about anything else that could try to help this gentleman.
CVID patients can have diabetes. So if you look at Charlotte Cunningham's nice review of CVID patients and the autoimmune manifestations of CVID, diabetes is one of those. So, whether that's because it's more common and more prevalent in the general population is hard to know, but that relationship is certainly there. And so in a patient like that, I would definitely look at antibodies and do your standard workup. Now, the other thing that's important to remember is in adult females, they could be carriers of diseases. So I have seen, a 54-year-old lady with aspergilloma, pulmonary aspergilloma, who was a carrier for CGD. So keep those diagnoses in mind and always think about the possibility that you, as a female, you could be a carrier of the disease. In that particular patient, I would look at the pathogens. What are the pathogens that were identified, and then understand, what are the ARNs that are required to clear those pathogens? And basically, you need neutrophil function, and you need antibodies for most of it, for the classic staph and strep infections. If it's an unusual pathogen, then it will guide you, and so that is really important.
Okay. Yeah, thanks. He's had methicillin sensitive now MRSA, unfortunately.
Thanks again.
I have this patient with pneumonia who's been, who was in ICU, intubated. He's like around 50 years, and for the past 10 years he's had many pneumonias. So his IgG level is borderline, IgM is borderline, but he had a good response to strep pneumo. But he had no class-switched memory B cells. And I tried for IVIG since he's had such severe pneumonias, it was rejected twice. So how do you interpret B-cell phenotype in his case, since that's one of the diagnostic criteria now? And my second question is, I repeated the strep pneumonitis a few months later just to see if there is any memory issues and reduced titers. There was some reduction, but not a significant drop. So how do you manage this case? I put him on azithromycin every other day and just monitoring him.
No, I think you're absolutely, your concern is that this patient has CVID or evolving picture and has an antibody deficiency and would benefit from immunoglobulin, and I agree 100% with you. And I would push for insurance to continue to be an advocate for this patient and try to speak with the medical directors or whatever insurance company because this patient may require. I agree with you in the meantime to try to do some prophylactic therapies the question is, how do you evaluate waning titers? And the answer is not very clearly understood. You could argue for specific antibody deficiency syndrome under the beautiful table in the practice parameters that define the specific antibody deficiency. And so if you check the titers, 3 months from now, they might be even lower. So that might give you an opportunity to use.
Thank you. For now, I think we also need some
I have very fears there.
Oh, great.
I'm getting myself in the car right here.
Oh, wonderful.
Yeah. You still working down?
Okay.
Anything coming here? Anything else?
She's gonna ask for the letters too. I'm gonna send you an invite for
All right, thank you again.
Oh, good.
3 weeks.
Come and join
So
me
this
for
is-
time
this was
Tuesday
better.
mornings. You can get away from the responsibility to come here.
Yeah, I try to come, as long as I don't have a clinic. I have clinic on Tuesday, so as long as they don't have me scheduled at 8, then
Tell them not to schedule it till 9.
theoretically, that's the case.
Yes. Because I think it's good for you to interact with our fellows
Yeah,
and
yeah.
the broader community. And
Yeah, I look forward to meeting the people in the community.
I was thinking next year to ask people to do a talk on the cost
I have that option.
ethics. I know there are
If we can
people
figure out a way that you
who
want to
said
do
to me
that, I
that
can
some
do
people
that.
in the group.
There's a inpatient.
So we offer samples of
No,
things.
not just that.
So we have representatives that
Thank you.
Didn't put my glasses on.
Oh, no,
I
it's
signed
totally
up wrong
fine.
one.
Oh, that's
There.
okay. It's
But,
totally fine.
I left anything off, so I can write it if you need it.
Yeah,
in my
no, it's
handwriting.
perfect.
So, yeah,
Thank
sorry
you.
about that.
this is actually so anyway, yeah, I can send you that if you want to send me.
I thought you were going to find a cup. That's why I was sending you to send your
Okay.
project sign.
Yeah,
Sorry
yeah.
about this.
So yeah, we are changing. So you're gonna be cracker about what's up.
Yeah.
From New York.
Yes, I do. Yeah.
You don't have to do it yeah.
That fade's nice. But just some of it is productive.
Yeah, it's true. After 5 o'clock, I'm still out. So anyway, your kids got it.
I have one for you.
I grew up down in the clinic, so my classmates I came out here. I taught wine education, so
Oh, great.
right out
Oh,
of the
great. So nice to meet you. Yeah,
I probably should have. And so I figured recently.
Just ask them questions outside.
Okay.
I've been bargaining transition of course, but I actually have something that I can offer to you. I have 2
So
long-standing.
do reach out if you want. I can send you forms back that are intake forms, so that it allows our services. We have mid-level services that we contract with because we can't get patient information to the patients, but we
And
have patient services that handle the HA patients.
So, yeah, that's where the whole office is over, and then,
I like that.
I'll get rid of this.
Oh, okay. Instead of HA.
one of my moms, and I just don't have to.
I have to clinic.
One of my moms that I worked with before, about, she has 7 sons, 5 have hyper IgM, 3 have passed, and she has 2 daughters that are carriers. And she just wrote a book. And can I send you a copy of the book? Okay. And it will be, this is Carrie. I'm
Hello, nice to meet you. Fantastic.
yeah. And it's
see
the
Dr.
mother's
Ayers
side
and
of
Dr.
these kids. And I was there as the practitioner, and I saw
I typically
different
don't go to
sides.
their office.
It opened my eyes. I was like, oh my goodness, I didn't think that at all. I didn't think that at all. So I will send you a copy of it. I also had another family that Troy saw, actually, the dad, and he has hyper IgM. He's now about 36. He has 3 daughters that are going to all be carriers. And a little girl. So he has, he's had a hard time grasping the concept that they're going to be carriers. But
Hey, how are you?
but by then,
I wanted to find out what's going on. With Dr. Yang, anything yet? Anything on doing lectures?
I don't
primary care?